Hello students, today I'll be talking about the anticoagulants, the parenteral anticoagulants apart from heparin and the oral anticoagulants apart from warfarin or the coumarin derivatives. So just to revise the classification of anticoagulants, as I told you earlier, you can broadly divide them into in vivo, in vitro, and the in vivo can be further classified into parenteral and oral. Among the parenteral anticoagulants, you had the indirect thrombin inhibitors, which included heparin, low molecular weight heparin, and fondaparinux. And you had the direct thrombin inhibitors, lepirudin, vivalirudin, agatroban. Then in the oral anticoagulants, you had the coumarin derivatives, warfarin, and other coumarin derivatives. And you had the direct factor 10A inhibitors, which include rivaroxaban, apixaban, edoxaban, and the oral direct thrombin inhibitor, which is dabigatran etizilate. So today I'll be discussing all of these apart from heparin, low molecular weight heparin, fondaparinux, and warfarin and the coumarin derivatives. Okay, from the feedback which I got from my lecture on heparin, I understood that there was some problem regarding the understanding of heparin resistance. So I have included heparin resistance in this lecture of mine. So to explain heparin resistance one more time, heparin, as you know, is monitored with the help of a test which is known as the activated partial thromboplastin time monitoring, and the normal values of this activated partial thromboplastin time is about 40 to 50 seconds. And when a patient is put on treatment with heparin, we expect a range of APTT to be roughly within 2 to 3 times this normal value of activated partial thromboplastin time. So when the patient is on treatment, the value of APTT can be roughly in a range of 2 to 3 times the normal APTT values because of the anticoagulant effect of heparin. Now, a moderately high dose of heparin, say a dose like 35,000 units per day, should ideally increase the APTT to 2 to 3 times the normal value. But it has been seen in certain patients the APTT value is subtherapeutic, which means that it has not been prolonged, even though the dose of heparin which this patient may be getting could be as high as 35,000 units of heparin given on a daily basis. And when this happens, we say that this patient is resistant to heparin or he has heparin resistance. Now, heparin resistance can be of two types. There is one type of resistance which is known as true resistance, and there is another type of resistance which is known as pseudo resistance. Now, to differentiate between true resistance and pseudo resistance, along with the measurement of APTT, another test which is applied is the measurement of the anti-factor 10A level. Now, what is anti-factor 10A level? You know that heparin has anti-factor 10A activity because it has it inhibits the action of factor 10A. So what we do is that in a sample from the patient, we compare the residual factor 10A activity to the factor 10A activity in a control sample which has been given a known amount of international standard heparin. So in that way, we measure the anti-factor 10A level in the patient. So when we do this anti-factor 10A level measurement, we see that in the case of true resistance, there is a decrease in the anti-factor 10A level, whereas in the pseudo resistance, the anti-factor 10A level is normal or therapeutic. So in this way, with the help of measurement of anti-factor 10A level, we can differentiate between those patients who have pseudo resistance to heparin or true resistance to heparin. So if the anti-factor 10A level is therapeutic, it means that the heparin is working. not that it is not working, but if the anti-factor 10A level is subtherapeutic, then it means that the heparin in this particular patient is not working. Now, the probable hypothesis which has been given to explain the cause of pseudo resistance is that they say that in these patients there could be an increase in the levels of factor 8, or there could be an increase in the fibrinogen levels. So even when you test for APTT levels before starting treatment with heparin, these patients will have a shorter APTT level. So this is in the case of pseudo-resistance, and we do not need to modify or change the level of heparin in those patients who show pseudo-resistance to heparin. Whereas in the case of true resistance, various probable reasons which have been given are, number one, they say that there might be an increase in the levels of plasma proteins which could be competing with antithrombin 3 for binding to heparin. So that is the most important cause which has been given, the presence of these plasma proteins which compete with antithrombin 3 for binding to heparin. The other probable causes could be, there could be roughly a 25% decrease in the levels of antithrombin as compared to normal antithrombin levels, and the different reasons which have been given for these are, for example, the patient may have cirrhosis, patient may have nephrotic syndrome, patient could be a patient of disseminated intravascular coagulation. So in these conditions, normally there is a decrease in the antithrombin levels. Another probable reason which has been given to explain resistance is that there could be accelerated clearance of heparin in these particular patients. So these are the probable reasons, and patients with true heparin resistance require an increase in the dose of heparin to get the required therapeutic levels of APTT and anti-factor 10. And in those patients where there is a significant deficiency of antithrombin, then this can be overcome by giving the patients antithrombin concentrates. So this was regarding heparin resistance. Okay. Now, those parenteral compounds which are direct thrombin inhibitors, they primarily include two types of compounds. There are some compounds which are said to be hirudin derivatives. Now, hirudin is the active principle or the active component found in the saliva of leech, which is responsible for the anticoagulant effect of leech. And these are synthetic compounds which are derivatives of hirudin, which include compounds like bivalirudin, lepirudin, and decirudin. And we have another direct thrombin inhibitor which is by the name of argatroban. Now there are certain similarities as well as certain differences which exist between bivalirudin and argatroban, which are highlighted in this slide. So coming first to bivalirudin. Bivalirudin is a synthetic shorter congener. It is roughly 20 amino acid congener, polypeptide congener of a longer polypeptide by the name of hirudin. And this bivalirudin has a direct inhibitory effect on thrombin, where it can inhibit both free as well as clot bound thrombin, and this it does by binding reversibly to two sites on the structure of thrombin, where one of these sites is known as the catalytic site and the other is known as the substrate binding site. So bivalirudin is capable of binding to both the catalytic site as well as the substrate binding site. So when bivalirudin binds to the catalytic site of thrombin, it inhibits the effect of thrombin in converting fibrinogen into fibrin, and the other effects of thrombin where thrombin has an effect on activating platelets or promoting platelet aggregation, that effect is also inhibited, and the effect of thrombin in activating the upstream clotting factors is also inhibited. And when bivalirudin binds to the substrate recognition site on thrombin, bivalirudin itself becomes a substrate for thrombin, where thrombin brings about a proteolysis of bivalirudin and is also responsible for reversing the effect of bivalirudin. So this is the mechanism of action of bivalirudin. Now, if you compare this with argatroban is also synthetic, similar to bivalirudin, and it is the nature of argatroban is that it is a congener of L-arginine, that is the chemical structure of argatroban. And argatroban binds only to the catalytic site of thrombin. It does not bind to the substrate recognition site of thrombin as was seen in the case of bivalirudin. And argatroban is also capable of inhibiting both the free as well as the clot-bound thrombin and exerting similar effects as are seen with bivalirudin. Now, a feature which is common to both bivalirudin and argatroban is that both of them have a rapid onset of action. The half-life of bivalirudin is roughly 25 minutes, and it is roughly double that in the case of argatroban, and both of them are short-acting. As far as antidotes are concerned, there is no specific antidote for either bivalirudin or for argatroban. So you have no specific antidote for both of these compounds. Another factor which is common to bivalirudin and common to argatroban is that in those patients who are at a risk of heparin-induced thrombocytopenia or where there is a history of heparin-induced thrombocytopenia, both bivalirudin as well as argatroban can be safely given in this category of patients. So bivalirudin, argatroban, and another compound, if you remember, I had mentioned when I was talking about heparin, a compound by the name of fondaparinux. These are the three alternatives which can be given to patients at a risk of heparin-induced thrombocytopenia. So thrombocytopenia is not a risk and is an indication for the use of these agents. Now, bivalirudin is primarily cleared as a result of renal function. So bivalirudin is not safe in patients with renal dysfunction, whereas in the case of argatroban is primarily metabolized by the liver and excreted through the bile. So argatroban cannot be given in patients with hepatic dysfunction, but argatroban can be safely given in patients with renal dysfunction. So the good thing is that if it is a patient at risk of heparin-induced thrombocytopenia with renal dysfunction, you don't give bivalirudin, you give argatroban. And if this patient has hepatic dysfunction, then you give bivalirudin and you don't give argatroban. Now, monitoring of bivalirudin is normally done with the help of APTT monitoring, where the values, the normal therapeutic range would be roughly 1.5 to 2.5 times the normal value. In the case of argatroban, it has been observed that not only the APTT but the prothrombin time of the patient is also increased, and especially if bridging is required in the case of argatroban with warfarin, then there might be a problem in monitoring with prothrombin time. So in those patients who require a bridging from argatroban to warfarin, they say that the monitoring of or the measurement of anti-factor 10A levels is a better test to be done if bridging is required with warfarin in the case of argatroban. Now, as far as the uses are concerned, both these compounds may be used for the prevention of and treatment of thromboembolic events in patients, and they are indicated especially in patients who require percutaneous coronary intervention or cardiopulmonary bypass surgery, and if these patients especially are at a risk of developing heparin-induced thrombocytopenia. And very commonly when these compounds are given For percutaneous coronary intervention or cardiopulmonary bypass surgery, they are very commonly used along with the antiplatelet drugs like aspirin, clopidogrel, or the glycoprotein 2B3A inhibitors. And bleeding, as I told you, is a common adverse effect with all the antithrombotic drugs, and bleeding, the risk of bleeding becomes much higher when these compounds are combined with each other. For example, if you combine anticoagulants with antiplatelets, then the risk of bleeding is higher. Okay, the other other parenteral anticoagulants, which similar to bivalirudin, are desiruridin and lepiridin, which are also hirudin analogs, and similar to bivalirudin, these two compounds are also primarily excreted by the kidneys, so they would require a dose modification in patients with renal dysfunction. And they are also used for treating thrombosis in the setting of heparin-induced thrombocytopenia. And desiruridin has also been used for thromboprophylaxis in patients who have undergone hip replacement surgery. So this is one thing which makes desiruridin different from lepiridin or bivalirudin. And there is another synthetic compound by the name of danapiroid, which is a factor 10A inhibitor, and the mechanism of action of danapiroid is similar to the mechanism of action of heparin. And if you remember the mechanism of action of heparin, heparin is an indirect thrombin inhibitor. Similarly, danapiroid is also an indirect factor 10A inhibitor. It is an indirect parenteral factor 10A inhibitor which potentiates the action of antithrombin 3. However, danapiroid is not a very popular anticoagulant. It is a mixture of polypeptides like heparan sulfate, which is roughly there in a concentration of 84%, dermatan sulfate, which is roughly in a concentration of 12%, and chondroitin sulfate, which is in a percentage of 4%. And it is given by the subcutaneous route in a dose of 750 units BD. And this does not really require monitoring, and there is no specific antidote also available for danapiroid. Now, coming to the oral agents which are there for anticoagulation, there is a compound by the name of dabigatran, which is a direct oral thrombin inhibitor. Now, dabigatran is available as a salt, where this particular salt is known as dabigatran etizylate. It is a synthetic compound, plus it is a synthetic prodrug. And as you know, prodrugs are those compounds which are generally in the inactive form, and they require conversion to the active form inside the body. Now, the conversion of dabigatran etizylate to free active dabigatran is carried out with the help of plasma esterases, and dabigatran is given as a oral capsule. Now, the problem with the intake of dabigatran capsule is the dose is 150 milligrams BD. The problem is that if there is a accidental opening of the capsule during administration, or if the capsule is chewed at the time of administration, or the capsule gets broken, it reduces the efficacy of dabigatran. So the ingestion has to be of an intact capsule, and the oral bioavailability of this drug is roughly about 6%, and 80% of it is excreted unchanged by the kidneys. As far as the pharmacodynamics is concerned, dabigatran competitively and reversibly blocks the active site of both the free as well as clot-bound thrombin, which is its mechanism of action. And as you can see, 80% of it is excreted unchanged by the kidneys, which means that dose modification would be required if the patient has renal dysfunction. Because dabigatran has a predictable anticoagulant response, routine coagulation monitoring of dabigatran is unnecessary. Now, as far as the clinical indications are concerned, it can be used for the treatment of acute deep vein thrombosis after bridging with parenteral anticoagulants, that is after treatment with a parenteral anticoagulant for the first 5 days of treatment, may be used for the secondary prevention of deep vein thrombosis also. And it is also used for stroke prevention in patients with non-valvular atrial fibrillation. Now, atrial fibrillation can be of two types. You have valvular atrial fibrillation or you have non-valvular atrial fibrillation. A valvular atrial fibrillation means that the patient may have a mitral valve disease, or the patient may have an artificial or a mechanical valve. Now, if the patient has a artificial valve, a mechanical valve, or if the patient has valvular atrial fibrillation, then dabigatran is a contraindication. And in this case, if you remember, warfarin may be given instead of dabigatran as a oral anticoagulant. So warfarin is a oral anticoagulant which can be safely given in patients with mechanical heart valves, but dabigatran cannot be given in patients with mechanical heart valves, because it has been seen that if in these patients dabigatran is given, it is associated with higher thromboembolic events and there is a chance of excessive bleeding. So that is why mechanical heart valves are a contraindication for dabigatran. And atrial fibrillation may be also because of other reasons, like for example increased systolic blood pressure, or could be because of a hypermetabolic condition, hyperthyroidism. So those are the other probable reasons for non-valvular atrial fibrillation. Dabigatran in very low OD doses has been tried in certain studies and has shown efficacy in prophylaxis in patients who have undergone hip or knee replacement. But it's not rampantly used for this indication, but some studies have shown efficacy. So this was regarding the use of dabigatran. Coming to the adverse effects and the drug interactions which can be observed or which are observed with dabigatran is, one, as you know, I keep saying it again and again, with all the anticoagulants, bleeding is the most common adverse effect which is seen in the use of anticoagulants. The overall risk of bleeding with dabigatran is in elderly patients with atrial fibrillation is roughly the same as is seen with the use of warfarin, which is also about 3%. But there is a difference in the nature of bleeding, where it has been seen that the risk of intracranial bleeding is roughly 70% less in patients given dabigatran as compared to patients who have been given warfarin. So the incidence of intracranial bleeding is less with dabigatran as compared to warfarin. However, it has been observed that the risk of GI bleeding is higher, especially in those individuals who are more than 75 years of age. Now, this is a ironical finding, and one probable hypothesis which has been given to explain why GI bleeding is higher with dabigatran and GI bleeding is lesser with warfarin is that warfarin has a more complete absorption. Warfarin has a roughly 100% oral absorption as compared to dabigatran, where the oral bioavailability is about 6%. So it is believed that the residual dabigatran which remains in the GI tract may be responsible for a higher incidence of GI bleeding in case of dabigatran as compared with warfarin. And dabigatran is a substrate for P-glycoprotein. If you remember your general pharmacology, P-glycoprotein is a efflux transporter, which means that it's a one-way transport efflux which is carried out with the help of P-glycoprotein. And for P-glycoprotein transporters, there are certain drugs which may inhibit this P-glycoprotein transporter. For example, drugs, this is not an all-inclusive list, but drugs like verapamil, ketoconazole, erythromycin, clarithromycin, they generally inhibit the P-glycoprotein transporter, which means they will reduce the efflux of dabigatran and may be responsible for increasing the plasma concentrations of dabigatran, whereas a compound like rifampicin, remember rifampicin is also a universal microsomal enzyme inducer, and rifampicin may also increase the levels of P-glycoprotein transporter. So if the patient is receiving rifampicin, there could be an increase in the levels of P-glycoprotein transporter, which may be responsible for decreasing the levels of dabigatran. So these are the drug interactions which may be observed with the use of dabigatran. Okay. Then there are certain oral direct factor 10A inhibitors. Why we keep calling them direct, either a direct 2A factor inhibitor or a direct 10A factor inhibitor, is that these compounds do not involve antithrombin 3 in their action as compared to heparin, low molecular weight heparin, fonda, Parinux or danipiroid. So they do not involve antithrombin, but they have a direct inhibitory effect on either thrombin or factor 10A. So among the oral compounds which inhibit factor 10A, we have these three compounds: rivaroxaban, apixaban and edoxaban. Now remember that all these direct inhibitors like dabigatran, rivaroxaban, apixaban, edoxaban, all of them are relatively newer compounds as compared to heparin and warfarin. So they have only recently been introduced in clinical usage as compared to heparin or warfarin, which are more of traditional compounds as compared to these compounds. Now, as far as the pharmacodynamics of these three compounds are concerned, it is the same. All three of them, rivaroxaban, apixaban, edoxaban, are capable of inhibiting factor 10A, whether it is in the free form in the blood circulation or whether it is in the clot-bound form. All three of them are given by the oral route. However, there is a difference in their pharmacokinetics. There are certain differences as well as certain similarities in their pharmacokinetics, where it has been observed as far as their oral bioavailabilities are concerned. Rivaroxaban has the highest oral bioavailability, which is about 80%, followed by edoxaban, followed by apixaban, and that is 80, 62 and 50%. However, it has been observed that if you administer rivaroxaban with food, it improves the oral bioavailability of rivaroxaban, whereas in the case of apixaban and edoxaban, at intake or simultaneous ingestion of food does not have any effect on the oral bioavailability of apixaban and edoxaban. As far as the onset of action is concerned, rivaroxaban and apixaban have onset of action roughly somewhere between 1 to 3 hours, and edoxaban is also something similar, like 1 to 2 hours of administration. So you can see that all three of them have a fairly rapid onset of action if you compare them with compounds, say, like warfarin. As far as the plasma protein binding is concerned, the plasma protein binding of rivaroxaban is roughly 95%, followed by apixaban, which is about 87%, and edoxaban, which is about 55%. Okay, as far as the clearance of these compounds is concerned, there are certain similarities where all three of them undergo renal clearance, though maximal renal clearance is seen in the case of edoxaban, which is about 50%, followed by rivaroxaban, which is about 33%, followed by apixaban, which is about 27%. Plus, rivaroxaban and apixaban are also metabolized by the kidneys with the help of a cytochrome P450 enzyme, which is CYP3A4. So CYP3A4 is also responsible for the metabolic clearance of rivaroxaban and apixaban, but has a negligible effect on the clearance of edoxaban. Now, what this primarily implies is that all these three compounds, rivaroxaban, apixaban, and edoxaban, require monitoring by measurement of creatinine clearance levels, and if the creatinine clearance levels are less than 15 ml per minute, these compounds should not be used, and if they are, say, in the range of 20 to 30 ml per minute, you should use them with caution. And edoxaban may be used in case of liver dysfunction, but rivaroxaban and apixaban cannot be used in case of liver dysfunction because of hepatic metabolism. Now, generally, when we talk about drugs being excreted by the kidneys and we talk about creatinine clearance, our stress is mainly on the lower levels of creatinine clearance, where we say that it should not be below a certain level, because if it is below that certain level, there are chances of overdose toxicity because of a reduction in the clearance of these compounds. Now, edoxaban is a compound where we note not only the, where noting the clearance levels is important not only in case of those patients who have a low creatinine clearance, but is also important for patients having a high creatinine clearance. What this means is that it has been observed in the case of edoxaban that if the creatinine clearance is higher than or equal to and above 95 ml per minute, then also the use of edoxaban is not recommended, because in these patients who have a higher level of creatinine clearance, there is a greater therapeutic uh, there is a greater clearance of edoxaban, which reduces the therapeutic efficacy, and the incidence of ischemic stroke has been seen in patients with higher levels of creatinine clearance when they were given edoxaban. So with edoxaban, you measure even higher levels of creatinine clearance are a recommendation for not using edoxaban, which has not been seen in the case of rivaroxaban and apixaban. As far as the dose is concerned, rivaroxaban is roughly 20 milligrams OD dose, apixaban is 5 milligrams BD dose, and edoxaban is roughly 60 milligrams OD dose. Sometimes for example, with apixaban, they may recommend a dose, a starting dose, say like 10 milligrams per 10 milligrams BD, and then you gradually taper it to 7.5, and then may taper it to 5, and then to 2.5, or there may be a gradual tapering of the dose with the use of these. Since the anticoagulant effects of these compounds are much more uniform and much more consistent as compared to compounds like unfractionated heparin, monitoring is generally not required with the use of rivaroxaban, apixaban, or edoxaban. Okay. As far as the uses of these compounds is concerned, they are used for prevention of stroke in patients with atrial fibrillation, and are also recommended for treatment of acute deep vein thrombosis or pulmonary embolism, and also indicated for the secondary prophylaxis of deep vein thrombosis and pulmonary embolism. Something about the starting time of these drugs is that is the time of starting these drugs is that here there was some confusion earlier, where in certain textbooks it was mentioned that with edoxaban bridging should take place with the parenteral anticoagulants, and the rationale was not clear for that, because all three of these compounds, rivaroxaban, apixaban, and edoxaban, have a fairly rapid onset of action. So earlier textbooks recommended that with edoxaban there should be a bridging with the parenteral anticoagulants, but now they say that with all three of them they can be started immediately, and the bridging with parenteral anticoagulants is not required when they are used for the treatment of acute deep vein thrombosis and for prevention of pulmonary embolism. Okay. For post-operative thromboprophylaxis in patients who have undergone hip or knee replacement surgery. I think there are much more studies which have been done regarding the safety and efficacy of rivaroxaban and apixaban. So these two compounds are generally favored for this particular indication as compared to edoxaban. Now, all of them are contraindicated for stroke prevention in patients with mechanical heart valves. So, if it is a patient of atrial fibrillation with mechanical heart valves, then remember rivaroxaban, apixaban, edoxaban, as well as dabigatran are not preferred. So, if you want to give a oral agent, then the preferred oral compound is warfarin. Okay, coming to the adverse effects, these compounds, as I mentioned, bleeding here again, bleeding is the most important adverse effect, and certain advantages have been observed over warfarin, where the incidence of intracranial bleeding with rivaroxaban, apixaban, and edoxaban is roughly 50% less as compared to warfarin. So, as to comparing dabigatran, rivaroxaban, apixaban, edoxaban with warfarin, with all four of them, the incidence of intracranial bleeding is much less as compared with warfarin, but the incidence of GI bleeding is higher as compared to warfarin. Here also the probable reason which they have given is that because of a lesser complete absorption of these compounds, there might be a higher incidence of GI bleeding as compared with warfarin. And also, if these four compounds are given in combination with the other antiplatelet drugs like aspirin, clopidogrel, or glycoprotein, 2B3A inhibitors, non-steroidal anti-inflammatory drugs, and that is aspirin. So there could be a higher incidence of bleeding. As far as the drug interactions are concerned, similar to dabigatran, all these compounds, that is dabigatran, rivaroxaban, apixaban, and edoxaban, are substrates for P-glycoprotein transporter. So all those drugs which either inhibit the P-glycoprotein transporter, or all those drugs which lead to increased expression of P-glycoprotein transporter, will be responsible for producing drug-drug interactions with these four compounds. Okay, now if you remember heparin and warfarin, we had specific antidotes. For example, in the case of heparin, you had protamine sulfate. In the case of warfarin, you had vitamin K, which was the antidote, because whenever there is a accidental overdosage, or when there is overdose toxicity, or if these particular patients who are otherwise well controlled with these anticoagulants, and if they require to go emergency surgery or some other invasive intervention, then a reduction in the anticoagulant effect is required. And this reduction in the anticoagulant effect is usually done with the use of these reversal agents or specific antidotes. So for a drug like dabigatran, we have a specific antidote which goes by the name of idarucizumab. I'll repeat, which goes by the name of idarucizumab, which is given IV, and chemically it is a humanized mouse monoclonal antibody fragment which has a very high affinity for thrombin as compared, which is roughly like it is 350 times more greater affinity for thrombin as compared to the for dabigatran. Idarucizumab has roughly 350 times more affinity for dabigatran as compared to the affinity dabigatran has for thrombin. So this makes this particular compound useful, and dabigatran, it's a tongue twister, dabigatran and idarucizumab, these complexes which are formed, they are excreted by the kidneys. Plus, in the case of overdose with the dabigatran, one other option which we have is to do dialysis. So dialysis can also remove the excess of dabigatran which is there in the blood circulation. So that is the other option. And in the case of rivaroxaban, apixaban and edoxaban, the specific reversal agent which we have goes by the name of anti-xanate alpha, which is also given by the IV route, and chemically it is a recombinant analog of factor 10A, which means that it is a modified factor 10A, where the affinity of antisenat for this particular uh, uh, the affinity of this particular compound, antisenat, is much greater to rivaroxaban as compared to the affinity of rivaroxaban, apixaban or edoxaban to factor 10A. But because this is a modified form of factor 10A, it does not form a part of the prothrombinase complex. So with anti-xanate alpha also, complexes form between anti-xanate alpha and rivaroxaban, apixaban and edoxaban. One prominent difference between between dabigatran, which is a direct factor 2A inhibitor, and rivaroxaban, apixaban and edoxaban, which are direct factor 10A inhibitors, is that you can do dialysis in the case of dabigatran, but you cannot do dialysis in the case of rivaroxaban, apixaban and edoxaban. The reason being that these three direct factor 10A inhibitors are much more bound to the plasma proteins as compared to dabigatran. So this makes dialysis less effective in the case of these compounds as compared to dabigatran, where dialysis is more effective. In case where these specific reversal agents are not available, then the options which we have are a prothrombin complex concentrate, or activated prothrombin complex concentrate, or a recombinant factor 7A, which may be used in the case of all four of these agents. That is in the case of dabigatran, in the case of rivaroxaban, apixaban and edoxaban. So these are, you can say, broad spectrum. And recently there is a compound which is another tongue twister, goes by the name of siraparantag. This siraparantag is still under trials, and it is believed to be a reversal agent for not only dabigatran, rivaroxaban, apixaban, edoxaban, but is also believed to be a reversal agent for heparin as well as low molecular weight heparin, but it is still under trials. So to repeat one more time, these reversal agents become important under two conditions. One, if there is a accidental overdosage or toxicity of these anticoagulants, say in renal dysfunction or liver dysfunction, or in those patients who are otherwise well controlled but require some emergency surgery, then these agents are useful. Okay, coming to the advantages of these newer oral anticoagulants, that is the direct factor 10A inhibitors and the direct thrombin inhibitors over warfarin, is, which I mentioned. I'll just read through them. They have a much more rapid onset and offset of therapeutic effect as compared to warfarin. If you remember warfarin, for the full anti-thrombotic effect of warfarin to take place, it requires roughly a 5-day treatment with warfarin, and that is why, if you remember, bridging with the parenteral anticoagulants is required in the case of warfarin. As in the case of these agents, bridging may be required in the case of dabigatran. However, even though dabigatran has a much more faster onset as compared to warfarin, and we do not require this bridging in the case of the direct factor 10A inhibitors. Warfarin has a half-life roughly about 50 hours or so, and all of these have relatively short half-lives. No lab monitoring is required in the case of these agents, whereas monitoring with the use of international normalized ratio is required in the case of warfarin. There are fixed dose guidelines according to indications in the case of these agents. With warfarin also, the indications are regulated with the INR recommendations, which will modify the dose of warfarin. The antithrombotic efficacy is roughly equal to or maybe a little better than warfarin, but the adverse effects, certainly the bleeding profile is better than warfarin as far as intracranial bleeding is concerned, where it is 70% less with dabigatran and roughly 50% less with rivaroxaban, apixaban and edoxaban. There are fewer drug interactions as compared to warfarin with these newer agents. So this broadly summarizes the uh, other compounds apart from heparin and warfarin, which are used as anticoagulants. Thank you so much.